All right, while we're having folks join in, I'm going to go ahead and just introduce the series for those who are new. My name is Damilola Jolayami. I'm with the Center for Behavioral and Addiction Medicine at UCLA. And this is the Case-Based Learning Collaborative on Stimulants CME series. And it's held on the first and third Fridays at 12 p.m. to 1 p.m. Pacific Central Time in collaboration with the sorry, can you go back to the last slide so I make sure I say everybody's name? Collaboration with the Los Angeles County Substance Abuse Prevention and Control Program and the UT Southwestern Clinical Trials Network Big Southwest Node. And obviously, the Center for Behavioral and Addiction Medicine is in the UCLA Department of Family Medicine. Thanks. Next slide, please. So the objectives, I'm going to go ahead and skip through this because we've seen this in all of the correspondence that have gone out. Just a few housekeeping items for Zoom. Next slide, please. All right, so please use the Q&A for questions and the chat for comments during the lecture. You can go ahead and introduce yourself in the chat right now. Just let us know who is in the room, your name, your affiliation, and what you would like to get out of this session. We have our CME evaluations that will be sent at the end of the session this month, so everybody can fill out the evaluations for your CME credits. If you have not yet received CME credits for 2023, we are working on that and we're trying to get that to you as soon as possible. There's closed captioning enabled for this meeting, so please feel free to hit the closed captioning if you would need that service. If you were looking for past presentations, please visit the CBAM website where past presentations and information is available. Our next session is Friday, June 21st, and it's important to note that this after this session, this will be the last session for the half of this year. We will resume again in the fall of 2024. So we are going to take a summer break for those who will be traveling, and we'll come back in the fall, and more information will be shared regarding that. But the new session is a new paradigm for treatment of substance use disorder, and that'll be on Friday, June 21st, 2024, at same time, 12 p.m. Pacific time. All right, so we're going to show our disclosures for a second or so, as required by our CME provider. And in the meanwhile, I'm going to go ahead and invite Dr. Shapta, who is our series chair, to introduce our speaker.
Thanks, Dami. It's my distinct honor to introduce a friend, Dr. Sheila Vakharia, who is the Deputy Director of Research and Academic Engagement at the Drug Policy Alliance. Sheila has been an amazing influencer in our field in terms of bringing to light issues that affect people who use stimulants. She helps Drug Policy Alliance staff and others understand a range of drug policy issues. Dr. Vakharia builds relationships with drug researchers and helps to advance policy-relevant research. She also mobilizes researchers in support of Drug Policy Alliance policy campaigns and organizes conferences on key issues in drug policy. Dr. Vakharia is the author of The Harm Reduction Gap, Helping Individuals Left Behind by Conventional Drug Prevention and Abstinence-Only Addiction Treatment. It's published by Routledge and it's out this February, so I encourage you to get the book. Before joining DPA, Dr. Vakharia was assistant professor in social work at Long Island University. She's worked as a clinical social worker in both abstinence-only and harm reduction settings. So she has a broad range of research interests that include harm reduction therapy, drug policy reform, drug stigma, overdose prevention, social work, and education. She's on the board of directors of Filter magazine. And as I said, she's got a PhD in social welfare, and that's from Florida International University, a master's in social work from Binghamton University, and a postmaster's certificate in addictions from New York University. So it's our great honor and pleasure to have Dr. Vakharia with us, and we're looking forward to hearing what you have to say. It's stimulants. Awesome. Talking about stimulants.
Thank you so much for having me today. It is my pleasure to be with you, and thank you to Steve for the invitation. Steve and I met in 2017 when I was actually the lead coordinator for a stimulant Harm Reduction Treatment and Policy Conference, which he attended and participated, and so many of the lessons that I learned from coordinating and planning that conference and since then have really guided this work and this presentation, and I hope you find it helpful. And there'll be time for questions at the end. Feel free to put questions in the chat or the Q&A in the meantime, and we'll just stack them up and get to them at the end. So first and foremost, we are talking about stimulant drugs. What are stimulants? Stimulants are a category of drugs that stimulate or activate the central nervous system. And on the street, people think of them as uppers. And, several drugs fall into this category, including crack and powder cocaine, methamphetamine, caffeine, and prescription stimulants such as Adderall and Vyvanse. And research suggests that millions of Americans across the country use stimulants every day. In 2022, it was estimated that 5.3 million people across the United States used some form of cocaine. 4.3 million used a prescription stimulant without a prescription, and 2.7 million used methamphetamine. While the majority of these people who used stimulants did not meet criteria for an addiction or a substance use disorder, a significant portion did. And in 2021, the last year for which we have this data, it was found that methamphetamine was the third most common drug for which people sought treatment in publicly funded treatment facilities across the United States, and cocaine was the fifth most common drug. The first and second most common drugs being alcohol and heroin for which people seek treatment. And so why is it that people use stimulants? As a harm reductionist, I find it really important when talking about drug use to first and foremost acknowledge that people use drugs for reasons, and people use stimulants for reasons. And understanding motivations and the reasons why people use drugs is very important when it comes to accurate messaging, harm reduction and treatment, and other policy interventions to help keep people safe. And so when we're talking about stimulant use, people use stimulants for reasons beyond recreation alone, although recreation is a big reason, but people also use stimulants to increase their energy, for feelings of euphoria, to be awake and to stay awake, for better focus and attention. People use it for performance enhancement. People use it to be more productive, to feel more confident. Some use it as a form of self-medication. For others, it increases sexual desire and longevity. It also, for some people, serves social roles in terms of gaining acceptance. And for some people, it's a way to manage stigma or suppress feelings of stigma. For others, it's a way to decrease inhibition. And there are many who use stimulants to lose weight and suppress appetite. And oftentimes I find that when we don't talk about motivation and focus instead on harms, it makes us out of touch with the people who we're working with. When we focus so much on all the reasons that you should stop using, or that your drug use might be risky or harmful for your health, and the negative consequences, we overlook the real drivers for use. And when we don't acknowledge the real reasons that people use drugs, it makes it harder for us to be useful and helpful, but also it ruins our credibility and our ability to form a therapeutic alliance and relationship with people. And so I think it's really important to put stimulant reasons up front at this conversation. And so I just told you that millions of people across the United States use stimulants every day. Yet increasingly, we are seeing more and more members of our community dying of overdoses that involved or had a stimulant on board. So I'm quickly going to do a little bit of an overview of the overdose crisis, because I find that starting with that can also help inform why it's so important for us to talk about harm reduction when it comes to stimulants, but also effective treatment options to help keep people safe. So experts far smarter than myself have come up with a way of understanding this overdose crisis that we are currently in the midst of. Those of you who've been watching the news or doing this work in the field and the ground and living in your communities already know that we've lost over 1 million people to preventable drug overdose since the beginning of this overdose crisis in the early 2000s. Estimates suggest that we lost upwards of 105,000 people to overdose in 2023 based on provisional data. And that made it the third year in a row where we lost nationally over 100,000 people to overdose. And so more than ever, it's really important for us to talk about drugs and how to keep people safe. So when we talk about this overdose crisis, many people call it an opioid crisis. And many people talk about it in ways that are often quite dated and are relevant to a certain time frame in this crisis. As I said, we're 25 years into this crisis, and over those 25 years, it's unfolded in very dramatically different ways over time across regions, from rural to urban areas, from the East Coast to the West Coast, and has impacted communities of different races, ages, genders, and socioeconomic statuses. And so I think it's really important when talking about this crisis for us to first and foremost make sure we're on the same page in talking about it as a 4-wave crisis. And so many of us are familiar with the framing of the first wave of this crisis that started in the early 2000s as we started to see increases in overdose deaths in which prescription opioids were the leading cause of overdose death. And I could get into all the reasons why this happened, but I'm sure many of you have read extensively and heard extensively about the explanations for this, right? We know that pharmaceutical marketing to both prescribers and insurers about the need to identify and treat pain early on, but beyond that, also the selling of certain opioid medications as being relatively addiction-proof or safer than other forms of opioids, and in particular could be used for various forms of pain that had otherwise not been treated with opioids in the past, combined with marketing strategies that incentivize providers to prescribe larger and larger amounts of these medications. And so that we saw an increased flood and availability of these medications through doctors' offices, through pharmacies, and people who were given these prescriptions, some of whom developed opioid use disorders and died of overdoses, also were sharing or selling their extra or surplus medications to friends, families, and members and loved ones. And so we also saw an increasing in prevalence of opioid use among people without a valid prescription, who then in some cases became dependent upon them or used them in ways that increased their risk of fatal overdose. We know that there were regional trends in terms of this first wave of the crisis. Many of us, kind of focused on the increased overdose death rates in the Appalachia region. And it was kind of also characterized as a largely urban phenomenon and one that was impacting blue-collar white people, but also younger demographics of younger adults, but also teenagers and larger populations of women, right? So that's kind of how the first wave of this crisis was depicted in many of our, in the media and from people's experiences as well, what they saw unfolding on the ground. And so as overdose deaths started to go up and the authorities became concerned about the increased availability of these prescriptions, there was a concern that these medications were too readily available. And so the pendulum then went and swung the other way. We saw state and federal authorities promoting policies to increase the enforcement against prescribers, but also who was dispensing these medications at pharmacies or so-called pill mills. And we saw a lot of messaging to kind of affect the behavior of prescribers to get them to cut down on prescribing. Yet one of the fundamental errors of this time was that on the one hand, we were here trying to squeeze the supply and reduce the available supply of prescription opioids, yet nothing was really done to address the fact that the demand for these drugs remained. And so what happened was many people ended up turning to the underground drug market for, first of all, diverted pills that they were able to purchase. But as those became less and less available and more expensive, oftentimes drug suppliers were offering a more affordable option, that being in the form of heroin. But since heroin is an unregulated drug of unknown potency from bag to bag with no labeling or indication of how many active milligrams were in these baggies that people were buying, people inadvertently were consuming large amounts of heroin and unable to kind of moderate their use or learn how to stay safe. And so we saw this second wave of overdoses start to increase. And at this time, heroin was also pretty affordable, and we had pretty good heroin on the streets. And so this kind of moment where people were not really getting their needs met with the above ground opioid supply, now all of a sudden turning to the underground drug supply, but that had no labels, no warnings, and no indicators for them to learn how to stay safe. And sadly, we saw an increase in overdose deaths in some of these same regions where prescription opioid deaths were very high. And as heroin-involved overdose deaths started to increase again, while there was some move to increase access to evidence-based interventions and medications, harm reduction programs still remained relatively under attack and relatively inaccessible in many communities. And so we saw a demand remained for opioid drugs, while at the same time, policymakers were increasing funding towards interdiction for heroin entering the country, increasing penalties, and doubling down on efforts to try to get heroin off our streets. Yet what ended up happening was we ended up having a demand that now could not be met by the underground drug market, because heroin is a semi-synthetic drug, meaning that it's derived from the opium poppy plant. And by taking so much heroin off the streets, it was hard for suppliers to meet demand by waiting for the life cycle of a poppy plant to keep up with them so that they could churn out more heroin for the streets. And that was when some very smart chemists in the underground drug market remembered that there was a potent synthetic opioid that had been invented in the 1960s by Janssen Pharmaceuticals called fentanyl that could be easily made in a laboratory without needing to be dependent on the life cycle of a plant. And so by procuring the precursor chemicals on the underground market, these underground laboratories were able to synthesize pretty quickly a high potency opioid that they could then fold into the heroin supply and still ensure that end users could get a bang for their buck, even though the heroin on their street was declining in quality. And that's when we started to see what many of us call the beginning of the third wave of this overdose crisis, starting around 2013 and 14 here on the East Coast. I'm in New York City, when drug users in markets in Baltimore, DC, New York City, Philadelphia, and Boston started noticing that their powder heroin, because on the East Coast we have so-called China white heroin that dissolves pretty easily into water. And so the fentanyl granules mixed pretty easily into the China white. And so people were buying what seemed to be regular heroin because they couldn't detect with the naked eye that there were granules of fentanyl in it. But that when it dissolved into solution, it was a different color and consistency. Also, when they found themselves injecting with it, it led to other kinds of symptoms. The onset of effects was very strong. People were also experiencing itching and other kinds of physical sensations that were not used to from the typical heroin supply. But also they noticed that it didn't have any legs, meaning that this heroin now all of a sudden didn't hold them over for 4 or 5 hours like it did before. This heroin, or this opioid that they were being sold, actually was wearing off faster. It had a fast come up, but it also didn't have legs. It wore off pretty quickly. And this wave 3 was also a really notable moment in the overdose crisis here on the East Coast and in parts of the Midwest, because drug supply chains aren't distinct. The heroin that ends up in a rural community is often from the same supply chains and similar supply chains that passes through our major cities. And so while we saw this kind of relatively rural phenomenon unfolding with newer overdose incidences among communities and rural communities involving prescription opioids and heroin for the wave 1 and wave 2, all of a sudden, the heroin supply chains were getting squeezed across the nation and across the East Coast. And so suppliers were introducing fentanyl into the drug supply chain so that even urban users who had not been exposed to prescription opioids the same way that those other communities had were now bearing the consequences of the policy choices that we had made to restrict access for those folks. Because now the heroin that many inner city users had become accustomed to, they'd known how to navigate it, they knew how to stay safe. Overdose deaths weren't astronomically high among these communities. Now all of a sudden their drug supply was unpredictable too. And this is when we started to see an increase in overdose deaths among racial and ethnic minorities as well. Something that has often been left out of the broader narrative, Black and Latinx overdose deaths, particularly in urban areas here on the East Coast and parts of the Midwest, starting to go up in this third wave. And so as this started happening, we also started noticing around 2015, 16, and 17, and you'll see here the yellow and the light blue lines that are now emerging, that cocaine and methamphetamine involved overdose deaths started to increase as we actually started to see heroin and prescription opioid overdose deaths go down. And so Dan Ciccarone calls this the beginning of the fourth wave of the crisis. So not only by the time the fourth wave emerged, were we seeing dramatically high fentanyl-involved overdose deaths now affecting urban communities, now affecting Black and brown people and older adults, we were also seeing the co-involvement of stimulant drugs. And the co-involvement of stimulant drugs meaning that people were either co-using these drugs together in speedballs or in goofballs, speedballs being using cocaine and an opioid together, or methamphetamine and an opioid together in the case of a goofball, but also potentially that people were using fentanyl, having those really harsh, like strong kind of down or suppressive effects, and then seeking out a stimulant drug to kind of afterwards offset some of that kind of sluggishness and kind of drowsiness that they were experiencing, and that inadvertently people's systems were vulnerable to the onset of all of these, polysubstance effects, and increasing the likelihood of a fatal overdose. Although some of these overdoses for sure probably had contaminated fentanyl in them, research still continues to suggest that the cross-contamination or the adulteration of a stimulant with fentanyl is still relatively rare, but we started to see this happening, right? So wave one, prescription opioids, a white face, a rural face, middle-aged or even on the younger side. And then here we are in wave four, it happening and impacting also Black and brown communities, people living in cities, not only in rural communities, but also this co-involvement of stimulants, and then also the death of older folks. And then what did our government do? Well, fentanyl overdose deaths are going up. Let's make sure that we tell suppliers and manufacturers and distributors that we are going to penalize them to the full extent of the law for introducing these drugs into our drug supply. Again, with the logic that if we crack down on supply, that somehow demand will go away, when really we know that people involved in the drug trade are only meeting a demand on the ground, and that often harsh penalties are not an adequate deterrent for these suppliers who often have big profit motives by staying in the game, right? Analogs, yet as you can see, the involvement of fentanyl and overdose deaths only dramatically continued to increase, and it didn't actually have a deterrent effect. But in addition, starting in 2018, we started to notice the emergence of now these novel psychoactives, many of which being sedative drugs, benzodiazepines, being added into the drug supply. And so drugs like xylazine, etizolam, nitazene drugs, and now a novel drug, now a sedative drug that's used both in human but in veterinary medicine called medatinamidine. I'm pronouncing it wrong, my apologies. And then what did we see as well? COVID-19 pandemic was in 2020 becoming the first year we jumped from 70,000 to 90,000 overdose deaths in 1 year, and then the 3 years since then crossing the border into losing over 100,000 people per year, and COVID-19 disrupting drug supplies, but also leading to isolation and job loss and housing insecurity and so many of these other factors. So again, I think it's really important if we're going to talk about how to save lives of people who use stimulant drugs, having the context of this broader crisis is I think really important. So what are some policy proposals that we suggest to reduce stimulant-related harms? First and foremost, we believe that we must be addressing social determinants of health, because we know that people who are medically vulnerable, people who are vulnerable structurally because of housing or lack of access to resources are most vulnerable to experience any drug-related harm, whether the drug they consume is alcohol or opioids or stimulants. So we need to think about, like, how are we helping to ensure that our communities are safe and healthy and their needs are being met because they are less likely to experience drug-related harms if they have those protective factors when they do choose to use substances. But also, it's really important for us specifically to talk about access to healthcare and services, including harm reduction and options for evidence-based treatment. And then lastly, to really think through how is it that we can reduce contact between the most marginalized people who use stimulants, people who are homeless, people who are of racial and ethnic minorities, people who are of sexual and gender minorities, and contact with law enforcement, because we know that contact with law enforcement, particularly for the most marginal, is in and itself a vulnerability for lethality. But we know that our criminal legal system is no place to send our most vulnerable people. And so when we talk about understanding social determinants of health and understanding how that plays out in risk environments, this is where that motivations for use really ties in, right? Because we know that people who have housing instability, who are on the streets, who are in the shelter system, in congregate living, oftentimes are dealing with some real challenges. And our current housing system is not built or equipped to meet all needs. And we know that for many people who don't make it in line early enough for the shelter, who've had traumatizing experiences in congregate living, who have pets or partners or too many belongings to qualify to go in, who have trauma histories and histories of being abused and robbed and assaulted in these kinds of settings, do not want to be in these situations. And so what we hear from a lot of these folks is, I use meth so I can stay up all night and walk the streets and keep myself safe and keep my belongings safe. And then I choose to sleep during the day on the street where at least, like, no one's going to victimize me while I'm out there. And so people kind of having to find ways to have their drug use actually self-medicate or offset the harms of their structural vulnerability. We also know that job and income insecurity or underemployment or undercompensation for work leads many people to engage in shift work or overnight work or work that can often be extractive and exploitative. And so people use stimulants to be able to work those long hours, to be able to sustain themselves in these really challenging work environments. And we know that for many people, sex work is one of these fields of work as well. And the both criminalization of engaging in sex work, but also the ability to make your ends meet through sex work, especially if you're marginalized and you're disenfranchised and not you have a criminal record and it's hard for you to get a job, or you're gender non-binary, or you're queer in a field or in a profession in which you do face discrimination. We know that all of those factors can tie together for the kinds of choices that people might be making. And we know that also for performance enhancement in the workplace or in academic settings can also be a driver for some people to use stimulants more than it may be safe or healthy for them. And we know that dealing with institutionalized and internalized homophobia, transphobia, heterosexism, all of these factors can be drivers for self-medication or use. And then understanding that when you are living in physical, emotional, spiritual pain, and you can't access adequate medical care, mental health care, or other kinds of treatment, physical therapy, or pay for that expensive surgery that you need, that oftentimes taking stimulants can be a way to numb yourself out, to not feel that pain, to be able to still push through, to be able to move on, to be able to get work done, to be able to still meet all of your needs. And so understanding the interconnectedness of all of these factors is really important. And so what are some of the policy solutions that we believe to address that can help address social determinants of health and keep these environments that people are in, make them less risky so that people are able to make autonomous choices around their drug use and choices to be able to stay safe, and that they're able to navigate their drug use in a safer way? So first and foremost, the importance of low threshold housing, including programs like Housing First, right? We know that there are many landlords, private and publicly funded, that conduct background checks on tenants before letting them move in. And so people with criminal records often are discriminated against. But we also know that in places like public housing, oftentimes your drug use or the drug use of a family member or one of your guests can be enough grounds, even if it's never verified, for you and your entire family to become evicted. And we know that lack of affordable housing can be really challenging for folks. And so it's really important for us to think about good housing policy, but also how when we're talking about our most marginalized, that their housing is safe and accessible and not at risk. Because oftentimes it takes a while to get adjusted into these new environments. And by putting the bar so high on requiring immediate abstinence or abstinence before they even have laid their head down on a pillow, doesn't really acknowledge the kinds of stress that they're in before that moment comes. We also need to talk about the importance of Medicaid expansion in states. I know many of you on this call are living in California, a state that is doing better than most in terms of ensuring that people at the poverty line and slightly above the poverty line still have eligibility for Medicaid. But there are many folks in parts of this country where without expanded access to Medicaid, they are the working poor who aren't getting subsidized insurance through their workforce, but also can't pay the out-of-pocket fees for buying insurance on the market, for instance, right? In like the ACA marketplace. We also need to think about all of the state and federal barriers to people with criminal records or people who test positive on drug tests from being able to access public benefits such as food benefits or cash assistance. And how, again, this only creates a self-perpetuating cycle where people who are food insecure, meaning that they don't have steady access to food, may actually find that using stimulants is a way to suppress my appetite and not actually get that hungry and to be able to manage the fact that I can't afford to feed myself, right? And then, of course, thinking about the ways in which criminalizing the activities that people may engage in to make money, most namely one of them being sex work, again, can only feed into more exploitation because there are many people who go into sex work voluntarily or because they've done a cost-benefit analysis that this is the best form of work right now, considering the options that I have. But then for those who are exploited and put into sex work involuntarily, they are just as likely to face criminalization as the sex worker who's engaging in voluntary sex work. And so actually policies that criminalize sex work don't decrease the risk of human trafficking. They actually increase the risk of human trafficking victims never getting the help that they need. And also the decriminalization of sex work can make sex workers feel more open in being able to seek access to help and services and not fear the criminal repercussions. And in general, we know that when workers are safe, people who are employed are safe, they have leave, they have sick time, they have benefits, they are more likely to be able to meet the requirements of their workplace. They're able to get the help that they need or take time off when they're not feeling well. But when people don't have these things, stimulants can really fill a gap for folks because it'll help me push through when I'm sick. It'll help me make sure that, I don't have to think about that for a little while and I can stand on my feet and work as a line cook because I need this, I need this money tonight because I have bills to pay, right? And then we know also that, for instance, for specific communities such as queer communities, having specific programming, centers, and services that are culturally specific and tailored to them is a way to ensure that specific communities who use stimulants are getting the kinds of services to help them learn how to stay safe, find options if they're looking like they want to cut down or, reduce risk, or if they want to seek treatment, right? And this brings up access to harm reduction and treatment. So I put this quote here by Sheila, who's in Seattle, because I think it's a really important one. When most people think about harm reduction, usually the first thing that comes to mind are syringes. And oftentimes thinking about syringes as it relates to injection heroin use or opioid use, right? And so that looks like providing syringes to folks, providing them with naloxone, and also just kind of building routines around what a typical opioid use schedule looks like. So back in the day when we still had access to heroin in our drug markets, people who used heroin would inject maybe 4 or 5 times a day, right? Pretty stable increments of time. When the withdrawal would start kicking in, people would start seeking out the heroin, use again, dose themselves to feel well. And then when the effects would wear off 4 to 6 hours later, starting to experience withdrawal and using again. However, when we're talking about stimulants, first and foremost, yes, there are some people who do inject cocaine. There are some people who inject methamphetamine. And sure, syringe access could be very useful and helpful to these folks. However, when it comes to stimulants like cocaine and methamphetamine, a lot of these folks are actually sniffing their drugs or they're smoking their drugs. And so the tools to smoke your drugs are not often legally available at syringe service programs in parts of the country. In fact, there are many parts of this country where it's legal or decriminalized to give out and distribute syringes, but it's still criminalized to distribute smoking equipment and pipes. And so when harm reduction programs were built around this, this injection model and policies were passed to decriminalize so that they could distribute syringes, we've left people who smoke drugs and use stimulants out of the equation, but also those who do inject stimulants do not just inject 4 or 5 times a day the way that we built our models around people who use heroin. Many times these are people who are skin popping or engaging in injections far more frequently. And so they're going through far more syringes if they are injecting. And so again, this kind of cultural shift that we need to acknowledge that like our harm reduction playbook was built around injectable opioids is a really important one for us to think about if we're thinking about how to keep people who use stimulants safe. And so I have a couple flyers here that I think are really fantastic, and they're made by they're made by Kat Humphreys, and she made them when she was at the Harm Reduction Action Center, although she's now at Vital Strategies. And here are some really great flyers that she made specifically on guides for harm reduction and stimulants and smoking and snorting drugs. And this is really important information for us to make available to folks, but also these are all the kinds of tools that we should be making available to people. Not only just the pipes, but the attachments to the pipe. So the rubber stem so you don't burn your lips. Also the kinds of filters that you put in because you don't want to just inhale potentially a rock or some other particle that you're lighting up. But also acknowledging that like people need condoms, people need tools for snorting if that's what they're choosing to do. And so all of this kind of information is really important and sadly not as available as opioid specific tools and messaging have been historically. And so I think, I'm kind of already alluding to this, but thinking about how when you can market your programs or your facilities as providing stimulant-specific resources and support, it can send a message to people who are co-using stimulants and opioids or people who are only stimulant users that there are still tools and resources that we have available to you, and there's information we want to be able to give to you. Because for the occasional stimulant user who may be at risk for adulteration in the cocaine that they buy, or in that slight chance that the methamphetamine that they buy is adulterated with fentanyl, having access to a fentanyl test strip is really important. But again, would they ever walk into a syringe service program to get it? No. But if they were told that they could get smoking equipment, that harm reduction provider could then have a conversation about, have fentanyl test strips on hand. This is how you dissolve your sample and potentially test whether you might have accidentally got cross-contamination of fentanyl in your supply. But also, here's an naloxone for you to use on yourself or a friend or a loved one. Just have it on hand. This is how you use it. And would you like an HIV test while you're here? When was the last time you were tested for Hep C? Maybe we can talk about getting started on some treatment, right? So using the law of attraction and like that idea that if you build it, they will come, to specifically target people who use stimulants and engage them in care. Because so often our work is, especially now as we continue to call it an opioid crisis, it leaves people who use stimulants behind and out of the question, right? And then thinking through what culturally specific outreach looks like for not only just queer communities, but also communities of color. As I said to you, the depictions of this overdose crisis in the 4-wave framework has really been a way for me to also talk about racial disparities in death. And one of the things that I didn't say when I was going through the wave 1 slide in the slide deck was that although narratives of the overdose crisis talked about high rates of overdose among white people, which was true, recent reanalyses of data, in particular by Joe Friedman and Helena Hansen, have actually revealed that Native people have been dying of overdose deaths at astronomically high rates since the beginning of this crisis. And because they were often left out of analyses in that first wave of the crisis, because they're such a small portion of the population, the impact of the overdose crisis on them in wave one has not been depicted as clearly, when actually Friedman and Hansen's analysis reveals that actually Native and white people had very high rates of overdose deaths in the first wave, and they've only continued to have high rates of overdose throughout all 4 waves of the crisis, and they have the highest rates of methamphetamine-involved overdose deaths in the country. And here we are in the 4th wave, and actually Black people have the highest rates of cocaine-involved overdose deaths. So again, when we're talking about this overdose crisis, and we're talking about racial disparities, and we're talking about stimulants, culturally specific outreach efforts in Native communities, by Native communities, for Native communities, and the same for Black communities is super important. And we've seen creeping increases in Latinx overdose death rates as well. And although they have not exceeded those of white, Black, and Native people, it doesn't mean that we shouldn't be providing specific outreach to them as well. And then talking about the ways in which people can be taught how to stay safe. Overamping is the phenomenon in which you consume high amounts of stimulant drugs such as methamphetamine and cocaine, and you may have elevated body temperature, you might have elevated risk for stroke, you might have a cardiovascular event or a heart attack. And you may also, have symptoms of psychosis or hallucinations and be very disturbed and agitated. And when people are overamping and they have high doses of stimulants in them, they may not ultimately end up having an overdose, which could be lethal, but the experience of overamping is one that for which many people seek medical care and services, or in which people could be intervened with and help to de-escalate and stay safe. And so I think it's also really important for us to talk about how to keep people safe when they've consumed too many stimulants as well. And I think, I kind of alluded to this earlier, right? This idea that in this 4th wave, we've got this twin epidemic happening where it's not just one, it's not just the other, it's often the combination of the two. And so what are we doing to help people stay safe if they're using fentanyl and oftentimes are offsetting the strong effects of the fentanyl with a stimulant drug? What are we doing in terms of making sure that folks have viable options for medications for opioid use disorder so that they can maybe reduce or manage their fentanyl use and maybe thereby also have an impact on how much they're using stimulant drugs? And so it's really important for us also to think about what kinds of other policies do we need to ensure that people who use stimulants have access to harm reduction and treatment. And I think for one, it also means that we need to not only decriminalize sex work, but we also need to decriminalize all drug using kinds of equipment, because as I said to you, not all 50 states have decriminalized the provision of safer smoking equipment to people. And so without access to safer smoking equipment, how are we engaging people who use stimulants into kind of walking in the door and hearing about other options and learning about how to stay safe? And I'm not even talking about the 20% of states in which even injection equipment is criminalized and there is not a single above ground harm reduction program in existence. So we still need to go a long way in terms of decriminalizing the provision of drug using equipment, but also beyond that, we need to talk about decriminalizing drug checking equipment, such as fentanyl test strips or xylazine test strips, but also the utilization of advanced chemical methods such as FTIR and mass spectrometry, which are 2 advanced chemical analyses that can be conducted on drug samples so that people actually get a breakdown of what's in the drug that they bought and what they're about to consume. Again, the more information we can give people, the safer they can be because they can make informed choices. Of course, we need to talk about the need for overdose prevention centers, places where people can bring their pre-obtained drugs and use them on site. I know that in San Francisco, you had a temporary center, an open air consumption space where folks could go, but it was time limited and it's been shut for over a year now. We here in New York City have two, and I know that Providence, Rhode Island is in the works of getting their program off the ground, but we need more overdose prevention centers so that people can not only inject drugs, but smoke drugs on site. I went to On Point, one of those two New York City-based centers, just a month ago, and they had a ventilation space where people were able to smoke crack inside. And I was there while people were smoking crack. I was also in the room as several people were, injecting fentanyl, and there was not a single overdose. There was not a single adverse event. But if there were, it was good to know that there were staff on hand to help them if they needed it, right? We also need to talk about the need for evidence-based treatments for people who want treatment for stimulant use. Contingency management is the best treatment that we have available for people who use stimulants. It's the use of rewards and vouchers and incentives to help promote behavior change. We know that people who use stimulants are incredibly reinforced by rewards and positive reinforcement, and contingency management kind of meets that immediacy need for folks while also incentivizing behavior change. And unfortunately, in many states across the country, stigma is a big barrier to using and implementing contingency management, but also insurance reimbursement is one of those challenges. But we also need to talk about what does it mean to provide people who use drugs a safe supply of drugs, one of known potency, quantity, and quality, as they are doing in Canada. In Canada, the health authority during COVID authorized prescribers to prescribe to patients who they knew had substance use disorders alternative medical pharmaceutical alternatives to their street drugs to reduce the risk of overdose. And they call this the Safe Supply Program. And so prescribers can prescribe stimulant medications to people who use cocaine and methamphetamine, and they can provide a wide array of opioids to people who are dependent upon opioids as one way of keeping people from consuming drugs of unknown potency in the drug supply. We also need to talk about the need for FDA-approved medications for the treatment of stimulant use disorder. Steve is a bigger expert on this than I am, but we are still without an FDA-approved medication for people who use stimulants, even though this is not our first stimulant crisis. You know, in the 90s, we had a methamphetamine crisis. In the 80s, we had a crack cocaine crisis. And yet we came out of both of those previous crises without a single evidence-based FDA-approved medication treatment for people who use these drugs. And so it's still really important for us to explore that and to do more to ensure that people have medications that work. But we also need to decriminalize medications for opioid use disorder, because many people who don't have access to a prescription or a prescriber or can't jump through the hoops of a methadone clinic are sharing these medications on the street as a form of community aid and mutual aid to take care of people who aren't feeling well. And when people aren't feeling well on the street, they use more than they anticipate. Their tolerance fluctuates, and this can also increase the risk of overdose. And we really need to have conversations about expanding access to methadone, because currently the models that we have for dispensing methadone are solely based in the methadone clinic system, a system which is incredibly punitive and carceral, and has a monopoly over how people can get this life-saving medication, but often has policies around testing and counseling requirements that do a better job of keeping people out of treatment than keeping them in treatment. And, you know, people who are maintained on methadone cut the fatal risk of an overdose by a half or more when they're staying on these medications, and we don't do nearly enough to keep people safe. And we also need access to these medications in jails and prisons, because the overdose crisis that's unfolding out here is also unfolding inside. Between 2000 and 2018, overdose deaths in jails and prisons across the United States went up by 600%. And we know that not getting treatment while you're in jail and prison doesn't mean that you're not going to use drugs. And it also doesn't mean that you won't use drugs the second you leave a facility. And we know that people whose tolerance goes down while they're inside are at risk of overdose within the first 2 weeks of being released from incarceration. Their risk of overdose being 27 times higher than the general population in that 2-week period. And we need to fund more stimulant-specific research on harm reduction interventions that work, treatment options that work. How can we provide other kinds of tools and resources? How can we evaluate programs to show that they're efficacious and then scale up their availability? And we need to reduce contact with law enforcement. We know that when you're queer, when you're disabled, when you're a person of color, when you're a Black person in particular, a contact with law enforcement can be fatal. It can be lethal. And we know that people with disabilities and mental illness are among half of the people who are killed by law enforcement every year. And then you zoom in even more and look at racial disparities, and it's atrocious. So we need to really talk about decriminalizing drugs to reduce the likelihood that someone is going to have fatal contact with law enforcement or with the criminal legal system. We need to talk about a regulated system and approach to providing access to these drugs and these medications. And we need to really reprioritize where our funding is going, from punishment to health, right? And as I've told you, even as we looked at the unfolding of this overdose crisis in the 4 waves, deaths consistently went up when we cracked down on drugs and law enforcement, when we didn't similarly, if not even more, invest in health approaches and thinking about why does demand for drugs remain and how do we keep users safe, right? And we need to talk about the importance of, like, why is it that people are dying of overdose in their homes? One, is it because no one's there to help take care of them? Are they using alone, in which overdose prevention centers can be helpful? But also, is it that they don't want to deal with law enforcement? Because oftentimes calling 911 during an overdose still means that you're going to, a medical emergency, you're going to get a law enforcement officer depicted to this, dispatched to the scene. And wanting to avoid contact with law enforcement is a huge reason why people don't call 911. And investing in, community building and strengthening community responses to drug use and wellness and mutual aid and collective support. So all that being said, I know I went over a lot of information, but I'm going to stop so that we have a little bit of time for questions. I'm sorry I went a little bit over.
No, thank you very much for everything, Dr. Vakharia. And we have some questions definitely in the Q&A. If I may read one of them to you, that would be great. So one of them was in regards to all the programs that you really well described, right? How can we promote these services to communities in need, like safe injection sites or safe usage sites, through word of mouth? What's the preferred method to do so? And also how to ensure that the privacy when they want to go to receive these services.
Yeah. So I think these are really important questions. I think first and foremost, I think that providers at these programs need to be able to do their jobs. And unfortunately, our laws make it really, really hard for these programs to open, to stay afloat, to fund what they're doing, and to be able to do it well. And even in a blue state like California, harm reduction programs are under attack. Santa Cruz, California, also El Dorado County, they are actually trying to shut down programs and not let them get off the ground, even in a blue state like California. And I'm sure many of you know that just because it's a blue state doesn't mean that people are with these issues all over the state. So first and foremost, it's really important for us to show up for these harm reduction programs so that they can stay afloat. We write letters to the editor. We show up at city council meetings. We say these programs are needed in our communities. Do not shut them down. Let's continue to fund them and keep them afloat. But then I think it's really important for us to boost the availability of these programs in our networks among the clients and the people that we serve. If you are working in a community program where you know that there is a harm reduction program, have them make flyers and give them and leave them in your waiting room. Have them come do trainings for your staff to tell them how to use naloxone, how to talk about naloxone in every visit with a client, how to make a sign to make sure that it's there so that when someone looks at your wall, that they know that there's a resource in the community. And also to have times where people can find out more and attend a presentation. I think it's really important for us to use our platforms to platform these programs, and to keep them afloat. I did see one question that I did want to respond to. So in terms of how do drugs get into jails and prisons, largely it's correctional officers. Security guards, correctional officers, and staff oftentimes make a lot of money by smuggling in drugs, whether on their person or through the packages that come in through the system. Family members are such a small, if not negligible, population of people who bring in substances, and it's also not in the mail that they send in. You can ask any wife or partner of a man who's incarcerated what she's had to be subjected to when she's had to come in and visit him in jail. They go through body cavity searches. They get their clothes taken off of them. So it is not the family members who are bringing in the drugs to these jails and prisons where people are overdosing. It is the correctional staff and security guards, so-called security guards. Yeah. Any other questions?
I have a ton. So if somebody wants to, from the audience, to unmute and ask a question, that's great. This is fantastic information. I know that there's a movement in the US to restrict personal liberties across the country. And I think often the people that I think about it most are people who are using drugs. There's cases now of women who become pregnant and are using drugs, and they may participate in research, or they may have other sorts of federal protection for their privacy, but states are now trying to find ways to get access to people who use drugs, personal drug behaviors that may be recorded in a record, a research record, or a clinical chart. What's DPA, Drug Policy Alliance, doing to address the issues of this increasing move to either take people off the street and put them into mandatory treatments or compulsory treatment sort of settings, or in this case, to actually abrogate personal liberties and to use information that may be in a chart or in a record against the person?
Yeah, so just to be clear that I understand your question. So the first question is, what are we doing around coercive treatment?
Sure.
First and foremost, I mean, what DPA is trying to do around coercive treatment is to fundamentally dismantle the arguments that are being made for coercive treatment. Because the argument that people make for why we need to coerce or mandate or shove someone into a treatment facility, first and foremost, is because we want to disappear the most marginalized people on the streets who make us uncomfortable. And the presumption is, okay, well, if we don't send them to jail, we can at least send them to a treatment facility for their own good. When really the root of the problem and why we're seeing people on the streets and sometimes their worst moments is because they've been displaced from housing and marginalized out of housing, and also the housing options available to them, such as congregate housing or shelters, are actually unsafe, disturbing, unsettling, violent places for them to be, and they'd rather be on the streets. And so we at DPA, first and foremost, acknowledge that no one wants to be on the street, but that if we don't have voluntary access to the actual things that people want and need, without a roof over your head, how can we psychiatrically medicate you? And how can we assume that you're going to take your medications as prescribed? How are you going to be able to manage the side effects of your medication? Are you going to be stable enough to engage in psychosocial treatment? But also, the efficacy of psychosocial treatment for people who are in active crisis is very low. We need to think of meeting their basic needs first, right? Thinking of Maslow's hierarchy of needs. If someone hasn't had their basic needs of having food to eat, a place to sleep, a place to call their own, and any sense of community, can we truly expect them to stop using drugs if it's actually a response to unlivable circumstances? And how can we not anticipate that if you have a bed to sleep in for 6-7 hours a night, that some of those symptoms might just go away on their own, and that what seems like psychosis to you could actually just be sleep deprivation. So I think that challenging some of those underlying narratives of even what is the problem and what are the roots of the problem is really important. And then in terms of people who are pregnant and some of the challenges that they face in medical care, increasingly we're doing a lot of work around informed consent for drug testing during pregnancy, so that you actually have to be told that you're going to be drug tested during a visit, and that you can consent or not consent to being drug tested. Because what we're hearing is that actually a lot of drug testing is folded into seemingly routine testing, and then people aren't actually told they've been tested, and then things start happening and unfolding behind the scenes, and then they find out that there's a case against them. And we're also hearing that when people don't disclose their testing practices, that research shows that Black pregnant women and pregnant people are often drug tested at higher rates than white patients, even though they don't use drugs during pregnancy at higher rates than white people do. And so we also know that when you don't disclose these practices, they can play out in really racially disparate ways that really harm communities.
Awesome. There's one more question in the chat, real quickly. It was from Kevin Kingma. Can you mention a country that is more successful in treating substance use disorder or stimulant use disorder, and what can we learn from them?
One more time, I'm sorry.
So can you mention a country that is more successful in treating substance use disorder and what we can learn from that?
Yeah, I mean, I think that one of the benefits of some of the European models is that they have more advanced availability for medication-assisted treatment for people who use stimulants. I do think Portugal is a great model in terms of both decriminalization, but access to voluntary evidence-based treatments for people, and more of the social determinants of health also being met. So better policies around housing, better policies around access to voluntary services as well. But yeah, I think, the US is behind the times in our lack of a medication option. I think we're also behind the times in terms of really regulating housing and ensuring that housing is a human right. We do not have a human right to housing in this country. We don't even have a right to food and nourishment. And when you are a person with a criminal background, if you've been arrested at any time, we have basically disenfranchised you from access to a lot of public benefits, housing, food, support, certain kinds of jobs, and we also don't let you vote. So yeah, I think that we have a lot to learn.
Great. Well, this is terrific, Sheila. Dami, you want to take us home? It's been wonderful. Your discussion today has been so